Bună dimineața și bine v-am găsit la primul eveniment online, de această dată marca Upgraded Events. Numele meu este Dragoș Rizică și sper că totul este în regulă și ne auzim și ne și vedem bine, fără peripeții tehnice pentru următoarele 60 de minute. Webinarul de astăzi este o introducere în programul complet de ortodonție Smart Straightwire, un program gândit special pentru medicii rezidenți și pentru specialiștii aflați la început de drum. Împreună cu Roberta am structurat acest program cu mare atenție pentru ca toate informațiile să fie aplicabile imediat în cabinet. Deci, dacă vreți un protocol de tratament care să vă dea o direcție clară și care să vă permită să tratați eficient peste 90% din cazurile voastre, Smart Straightwire este ceea ce căutați. În plus, pe lângă acest webinar, Roberta va susține un curs de o zi și jumătate la București, unde veți înțelege mai bine ce fel de informații valoroase veți acumula în cadrul programului nostru. Cei care s-au înscris la acest webinar vor avea parte de o surpriză, așadar rămâneți cu noi până la final pentru a descoperi despre ce este vorba. Acum, pentru că timpul speakerului nostru este limitat, îmi face o mare plăcere să vă prezint lectorul acestui webinar, Dr. Roberta Lione, și de aici vom continua în limba engleză. So, Roberta, first of all, thank you very much for accepting our invitation today, and most of all, thank you for agreeing to bring the Smart Straightwire program to Romania. If you'll allow me just a short introduction before moving on with this presentation. So Roberta is a professor and a research fellow at the International Medical University of Rome, Unicamilus. So teaching for her comes natural. You will see that today and during the entire Smart Straightwire program. She specialized in orthodontics in 2011 at the Tor Vergata University in Rome, and since then, her credentials include the Italian Board of Orthodontics certification, which she obtained in 2019, followed by the European Board of Orthodontics certification in 2021. She is also Invisalign certified since 2014, marking her commitment to modern orthodontics as well. In addition to her academic and clinical accomplishments, Roberta is an active member of key professional organizations such as the Italian Society of Orthodontics, SIDO, European Orthodontic Society, EOS, World Federation of Orthodontics, WFO, and AIDOR, and this is just to name a few. She has authored numerous publications in both national and international journals and is a highly requested speaker at the orthodontic conferences across the globe. To mention only SIDO meeting, which in my opinion is the best orthodontic event in Europe right now, and of course the AAO, the most prestigious orthodontic meeting in the world. Roberta was just telling me earlier that she will also be attending the AAO next year. This is why I am even happier to have her today with us for this webinar. Roberta?
Thank you very much. Thank you very much. Good morning, everybody. Thank you very much, Dragos, for the extended presentation that you have made. So I'm very proud to be here. For me, it's a very good chance that we have to share knowledge. I met Dragos several years ago when first came in Bucharest. Like I remember like six years ago. Yeah, 6 years ago, because my second son was just born, so I came with him.
Oh, yeah, you're right. Yeah,
and
yeah.
he was 1 month old, I remember. And since that day, we had a very good and beautiful relationship and professional relationship. And when he asked me to join him in this 1-year program, I was very, very happy, because I know that Dragos is able to organize in a perfect way every kind of teaching program. So thank you very much. If you agree, I can share my desktop.
Yes, please.
So we can start with, yes, with the presentation. Give me 1 second to set everything in a proper way. Okay, perfect. Can you see?
Yeah, perfect.
Okay. So hello, everybody. I don't know who is on the other part of the screen. I know that you are all orthodontists. I'm very eager to meet you in person and to listen to you about your doubts, about your practice, because that every time I lecture in different places, I love to listen to everyday problems, everyday habits, because it is a very important way to increase our knowledge and to grow together. Today, it is just the first approach that we can have together to meet each other and to understand which are the potential of the straight wire technique. I've been training a lot. I've been trained a lot from the greatest orthodontist in Italy. So I've been taught by Davide Mirabella, by Raffaello Cortesi, by Arturo Fortini. There are some of the greatest orthodontists in Italy, but I decided to move also to San Diego to meet McLaughlin in person. My story starts from Salerno. I was born, just to introduce me a little bit and make a little connection between us. I was born in Salerno. It is a small town in the south of Italy. I'm very, very lucky because it is not because it is my home, but it is one of the most beautiful places in Italy because I live very close. I live on the seaside, and I live very close to the Amalfi Coast. That is a very special and incredible place, as you can see in the pictures. Then I moved to Rome, of course, and then in Rome, I started all the educational path that Dragos already mentioned. Those are my medals, if I can say so. I work at the university because my first commitment and my greatest passion is to teach and therefore to share. Teaching at the university is something challenging, is difficult, but at the same time, it allows to me to be every time updated. So I love teach, but first of all, I love make scientific research, because through my scientific research, I can design standardized and effective treatment protocols. So sometimes research is not considered something useful to clinical practice, but in my opinion, it is quite the opposite, because through my researches, I can modify, I can fine-tune my clinical approach, and it is very useful. So during the last years, I worked a lot in my educational path. I work a lot in my research activity, also because I had the lucky to meet my mentor, that is Professor Paola Cozza, and she introduced me all the other professors, and she mentored me for the last 20 years. And but I also worked a lot on researching excellence in my clinical practice. For me, it is very, very important to have good and predictable results. When I have good results, I'm happy, but I really strive for excellence every day. So I obtained the Italian board certification and the European board certification, that are not just medals, but through those exams, I learned a lot. I had the opportunity to revise my clinical case in a retrospective way. I was forced to understand my mistake, where I was used to make mistakes, and how to have overcome and to manage and to avoid my mistakes. And in this way, I could really enrich my clinical activity and elevate my clinical activity. And finally, in the last picture that you see on the right side, there is my office, my private practice in Rome. this was a big challenge as well, because I was used to work in a public hospital in Rome, and I had to change completely my mindset, completely and totally my mindset to run in a proper way my private practice. That was not easy for me, because I really didn't have any kind of skills to marketing skill, management skill to run the private office. So during the last 3 years, I worked a lot on on study about how to run my private practice, and nowadays I'm very satisfied because it is going very well. Have a private practice. It is not common. It is not still common in Italy to have a private practice, especially for an orthodontist. But it allows me to work exactly in the same I like, exactly with the space I like, with the time I like, with the equipment I like, and I don't have to compromise in any kind of aspect. As for example, I was forced to do when I was an external consultant. As I was saying before, with my university team, we travel a lot to meet the greatest orthodontists in the world. And I'm proud to say that I learned the MBT technique from, of course, the founder of the MBT technique, that is McLaughlin. And I don't have the picture here, but had the opportunity also to lecture with Dr. Bennett from London several times. So I never met Trevisi, because he was used to live in South America, but I had the chance to meet McLaughlin and Bennett several times, and they shared in a very generous way their knowledge. So I was privileged to have this kind of meeting. Of course, we know that when we talk about MBT technique, that is the topic of our one-year program, we start from the original straight wire that was born in 1980. When we talk about the original straight wire, of course, we are talking about the first generation of pre-adjust appliances. And when we mention the word pre-adjust, it means that we are going to use braces that have all the information required inside the braces. So pre-adjusted braces means that we have already the information of tip, so you can see that the slot is inclined, is not horizontal, but is inclined, and have the prescription is the sum of all these values. It means that the braces have already the value of in and out according to the thickness and the dimension of teeth, and it means that our braces have the torque value already inside the appliance. So when we applied the straight wire, we can skip some kind of arch wire bands. We are help in our practice, because of course we decide what kind of prescription want to apply in our patients. And when we're going, and during the one-year program, the first lesson will be dedicated to a deep understanding of the prescription. Because if we know the prescription that we are going to use, we know the change, we can preview and pre-visualize the changes that are expected in our patient during treatment. Of course, the prescription is made according to dimension of teeth, according to the class, according to the type of malocclusion. But we arrived during the MBT evolution to a very simplified biomechanics that can be easily adjusted, but little adjusted according to patient requirements. The first change that MBT, so that the MBT technique made on the straight wire original was not only on the prescription form, so they changed not only the value of teeth, torque, and in and out according to their experience. But the first and maybe the most important changes that McLaughlin, Bennett, and Trevisi made on the straight wire technique was to apply not heavy forces, so they replaced heavy forces with light and continuous forces. They replaced and they applied the sliding biomechanics. Essential is the precise bracket positioning, and therefore during the one-year program we will have also practical classes to obtain a very precise bracket positioning that can avoid a lot of mistakes. We have to learn how to manage the anchorage system, because the MBT, the anchorage management, is very easy. It starts from the very first phase of treatment, and it is easy because we have simple and simplified tool like the lace back, the band back, and the tie back. And therefore, we will have the chance to learn about the amount of forces, to learn about the sliding biomechanic, the bracket positioning, and lace back, band back, and tie back. And today I have prepared, just to show you and introduce you, because we have a limited time, one case that can explain how it is easy to treat our patient and to achieve all treatment goals if we are able to use the prescription, the anchorage system, the light forces, the sliding biomechanics, and all these tools all together are the potential of a simplified biomechanic technique. So I want to start talking about an adult patient with a class 1 malocclusion. An adult class malocclusion because, of course, we are going to talk also about interceptive treatment during the one-year program, but for now, the adult patient, the permanent dentition allow us to be focused only on the biomechanics of the MBT technique. That is the focus of this morning webinar. She is an adult patient. She came to my office with the chief complaint of crowding and, of course, with the chief complaint of an unpleasant smile. She was the daughter of one of professor of mine, so I had to pay a lot of attention during the treatment, and she refused to any orthodontic treatment during the previous years. But when became a young lady, of course, she needed something better for her smile. Every time we approach a clinical case, we should never ever skip the diagnosis process. And for me, it is a very fundamental step of my teaching approach, because I love talk about biomechanics, I love talk about forces and technical aspect, but what make me very passionate about orthodontic is the diagnosis. And diagnosis, in my opinion, is all the time underestimated, because of course we say, okay, it's an adult, a class 1 malocclusion, we just have to align. And this is the very first mistake that we have to avoid. So every time I'm gonna to discuss with you a clinical case, you will have a lot of space reserved for diagnostic process, because we can treat what we see. We cannot treat what we wasn't able to diagnose. So when we start the diagnostic process, we start all the time from a clinical evaluation, aesthetic clinical evaluation. So for example, this lady presented with a symmetric face. The lips were competent and full. Of course, we have an unpleasant smile, but although the presence of an unpleasant smile, we have a good incisor display during smile. Incisor display means that we have a good exposure during smile of both white and pink tissue. That is something very important in our clinical evaluation, because when patient come in our office, maybe they don't want a class 1 occlusal relationship, but for sure they want beautiful smiles, and therefore the display of the of tooth and gums is a very key factor to obtain beautiful smile. When we look at the profile, we can see that we have a slight convex profile. She presented with an increased lower third of the face. The lower lip is overexerted, and we have a slight protrusion of the anterior limit of the dentition. This is the occlusal, the intraoral view of our patient, of our lady. And looking into details, we can see that we have, of course, a permanent dentition. We have a regular upper arch. There is an important value for the upper crowding, so we are missing 6 millimeters of space. This is very important because a lot of time I hear my colleagues and they say it is a slight crowding, medium crowding, a severe crowding. But what is it is important is to understand also the amount of crowding. So 6 millimeters can be severe, like 9 millimeters, but between 6 and 9 millimeters, there is a very big difference. So when we define the occlusal condition of our patient, we should learn how to be very, very precise. So there's a crowding of 6 millimeters. There is a vestibular ectopic eruption of upper right canine. And we have a mesial rotation of upper first molars. There is present also some degree of sagittal asymmetry in the upper arch, because of course the first quadrant mesialized because we have a loss of contact between the first premolars and the canine. About the lower arch, we have a good shape of the lower arch. There is a severe crowding, but severe crowding for me means that we are missing 7 millimeters of space. There is a normal curve of Wilson, and also in the lower arch there is some sagittal asymmetry because the third quadrant mesialized due to the loss of contact between the lower left canine and the lateral incisor. Looking at the look-occlusal relationship, we have a class 1, very solid class 1 molar relationship. There is no COCR discrepancy. This is something very important, and this is something that you should evaluate every time during your first approach to patient. And there is the presence of thin gums. So we have to be very careful when we are going to move our teeth, and we have to be sure that we are going to move our teeth between inside the alveolar bone. There is midline discrepancy. The midline discrepancy should be measured as well in the same way as the crowding. So there is 2 millimeters of midline discrepancy, and it is mainly due to the fact that the lower midline is deviated through the left side. Also, the upper midline is slightly deviated to the right side because of the ectopical upper canine, but is mainly due to the lower midline deviation. When we have to make the evaluation of the midlines, of course, we're going to check the occlusal relationship, but we're going to check also at smile, comparing the midlines with the midline of the face. And all these values are necessary to start engineering our movement, to start a good programmation, a good planification of tooth movement. When we look at the panoramic, at the initial panoramic, everything is fine. We can see that there is a permanent dentition with erupting wisdom teeth. And be careful at your panoramic, because if you look careful, you can see that that is the presence of a supernumerary tooth in the first quadrant that is highlighted by a circle between the lateral incisor and the permanent canine. Of course, before starting moving teeth, and consequently before starting the root of our teeth, it is necessary to perform a surgical removal of the supernumerary teeth. I just go back 1 second, because you can see that here in the panoramic, that is a bidimensional image of our patient, the supernumerary teeth seem very, very small, but when we perform the surgical removal, and the surgeon decided at that time to perform the surgical removal without asking for a CBCT, the supernumerary teeth was quite big with a very well formed root. So the surgical removal was a little bit more difficult than it was expected. So pay attention every time you see supernumerary teeth or radiological images that you don't like. The CBCT is a very helpful during this case. Once we have removed the supernumerary teeth, we can keep on going with our diagnostic process. This is the lateral cephalograms with all the values. When we perform the cephalometric analysis, it is not necessary to select a lot of values. We can select some values, because we should have very clean in mind the information that we need. So sagittal relationship, vertical, what we really need for the sagittal skeletal relationship, for the vertical skeletal relationship, and for the dental base relationship. So when I teach to private course, I'm used to select like 15, no more values, because we have to go straight to the information that are very required to make diagnosis. So about the skeletal condition, we can see that our patient is a skeletal class 1 relationship. There is a biretrusion of both upper and lower arches. The patient presented with an increased vertical dimension. The upper incisor resulted normal positioned and with a good inclination respect to the maxillary bone. And there are a lot of systems that we can use and learn together to exactly evaluate the position of the upper and lower dentition respect to the skeletal base. While the lower incisor, there is a slight protrusion and increased inclination of the lower incisor respect to the mandibular basal bone. Also because we don't have to forget that the mandibular base is clockwise rotated, and therefore we have to adjust the position of the dentition according to the vertical dimension. With the MBT technique, it is important also to perform a soft tissue cephalometric evaluation, because we have to understand the position of the upper lip respect to a reference line that is named the true vertical line. We have to understand how it is positioned the upper incisor, because we have to move our teeth according to the aesthetic demands of patient. And in the same way, we are going to check the position of the lower lip, the position of the chin, and the position of the lower incisor. Only if we put together the skeletal diagnosis and the soft tissue analysis, we can design and plan movement that will improve the aesthetic appearance of our patient. Also, keeping in mind the aging process of our patient. So also keeping in mind the changing that are going to happen on our patient, very slow but inevitable during the aging process. So for this specific case, we can see that we have a slight protrusion of the soft tissue, of the A point, of the soft tissue A point, of the upper lip, but we have more pronounced protrusion when we move from the maxilla to the mandible. So we have an increased protrusion of the lower incisor, of the chin, of the beconium point on the chin of our patient. And we have to keep in mind this information to plan appropriately the treatment strategy. And when we have to decide between the treatment strategy, we have to write it down a problem list. This is very important. I know that this takes some time, but especially when we begin with the first clinical cases, it is important to write down all the problem list and to find a solution for every problem of our list. Remember that we are going to treat what we see. We are not going to assess what we are not able to see. And when we have a lot of patients and we start working early in the morning and we finish working late during the day, most of the time we forget all the data, and therefore to write it down a problem list is a very good reminder and will help us to keep the path and not losing the path during treatment. Because remember that if you want to achieve excellent result, your treatment should be well performed from the very beginning till the end. So no mistakes, no delays during treatment.
I'm sorry, Roberta, can I stop you just 1 second? Someone is asking for the cephalometric analysis slide once again, if you can just go back to it.
This one.
Yeah. Okay, probably if she wanted to see something, and now you can continue. I'm sorry.
Okay, I don't know if you have to stop 1 second on this as well. Soft tissue. Okay, and go on. So, for example, if our patient is B-retruded, of course, we have to pay attention to not move back the upper teeth, otherwise we will make worse the anterior limit of the dentition. The same is for the lower dentition. When we have an increased vertical dimension Of course, we don't have to increase furthermore the vertical dimension of our patient, but we have to pay attention how to manage the rotation of the mandible through the dental movement. And we have to keep in mind that the lower position of the lower incisor will be directed also by the direction of by the growth direction of the mandible. We have a severe crowding, so we need 7 millimeters of space, both in the upper and in the lower, to align teeth. We have protruded lower incisors, so for sure we don't have to retrude the lower incisor. And this is very important because we have to retrude the lower incisor to allow at the same time any anterior rotation of the mandible to improve the vertical dimension. We have to recover a good position of the lower midline to correct the midline discrepancy, and in this case it will be mainly the lower to move to the right, and we have to manage the vestibular eruption of the upper right canine, especially for the aesthetic final outcome, because we have to manage the gingival appearance of the patient, and therefore we have to be very careful when we move the upper canine. So the treatment alternatives, the two main treatment alternatives that we have with this patient is to perform an extraction strategy or to perform a non-extraction strategy. If I go back, of course, if I have the need to find 7 millimeters of spaces, and if I have the need to not further protrude the lower incisor, and if I have the need to manage in a proper way the increased dimension of the face and to manage to reduce the clockwise rotation of the mandibular base, of course, for this case, the extraction treatment strategy is the most is the best for our patient. But when I talk about extraction treatment protocol, the second step that I have to make and the second choice that I have to make is to choose what kind of teeth, what teeth should I remove during my extraction strategy. And when we talk about a class 1 malocclusion, we have some conventional extraction pattern. We will learn also about the extraction pattern during the 1-year program. And the alternatives, the conventional extraction alternatives for class 1 malocclusion is or the extraction of the fourth first bicuspid, or the extraction of the second bicuspid, of the fourth second bicuspid. In this case, for my patient, I decided to extract the first bicuspid for several reasons. First of all, because the indication of the first bicuspids are class 1 molar relationship, are severe crowding, is the dental alveolar B protrusion, and I have more reason also to add to choose this kind of extraction pattern. So for example, I want to retrude the lower incisor, therefore I need space immediately behind the canine. I need spaces immediately behind the canine also because I have the vestibular eruption of the upper canine. So if I recover space behind the upper canine, I will be facilitated during the extrusion of the upper canine. Also because I want to be very effective during my biomechanics, And if you look at the lower arch, you can see that I have also mesio-inclined and rotated lower canines. So if I remove the first bicuspid, immediately I can find space where I need, and I will have a very easy and fast recovery and relieving of all the occlusal problems. Of course, during the management of extraction space, I have to pay attention to manage the movement to recover the lower midline position, to recover in a proper way the sagittal asymmetry of the lower arch, and I don't have to lose the class 1 occlusal relationship that my patient already has. So this is the a visual schematic simulation of my patient. So you see that if I extract the first bicuspid, that according to my diagnostic process is the best choice for my patient, how I'm going to use the extraction space. This is a very important because I have to manage the anchorage during all phases of my treatment. So to manage the anchorage, I have to decide how much my canine will go backward, how much the posterior unit can go forward. So I extract the first bicuspid, so I have 7 millimeters of space. How I can manage this, how I have to distribute this space. And if you remember, I told you that in the lower arch, I have 7 millimeters of crowding. That means 3.5 on the right side and 3.5 for the left side. It means that of my 7 millimeter of space, I will retract 3.5 millimeters the canine to allow a proper alignment and level of the anterior unit, and the remaining space will be used for a mesialization of the posterior unit that will help me also with the clockwise rotation of the mandible. So for this specific space, I need a medium anchorage. That means that both the anterior unit and the posterior unit will go forward and backward, and they will meet in the midway of the extraction space. So for this specific space, I don't need additional anchorage system like mini screws, like Nance button, like extraoral traction, but I can manage the anchorage just using the MBT system, that is lace back, bend back, and tie back. So we can start our treatment. The patient started with the extraction of the 4 first bicuspid, as you can see. You can decide if bonding both arches at the same time. I usually bond 1 arch per time. So I started with the bonding of the upper arch. And now we start with the tip and tricks, because look at the upper arch. What I want to do, I want to extrude in a very, very soft way the upper canine, because I have thin gums and because I have to manage the gingival level. I have to correct, of course, the crowding. I have to align and the level. So the tip and tricks during the first phase of treatment is, first of all, decide the positioning of the bracket. The braces positioning should be very precise, but for example, for this case, I apply some strategic positioning. So since I have to retrude, because I have to close the space of the extraction, since I have to move backward the upper canines, I have to manage the side effect of upper canines retraction. So if I apply the lace back, what I'm got, I don't know, you can see my hand. Okay, so if you want to retract the upper canine by applying the lace back, I have the risk side effect to disto incline the upper canine. That is not good, because if I lose the proper distal tip, I will not have at the end of my case a proper canine guide during disclosure movement of the mandible. So to manage the side effect of retraction of upper canine, I position the braces on the upper canines with an increased mesial direction, because I want to, I don't want to correct the distal tip at the end. I want to prevent the side effect. And this is the first tip on both upper canines. The second tip that I want to show you, here you can see the visual schematization scheme for the treatment stage. The second tip on the upper canine is to make a partial engagement of some teeth. If we look in detail, we can see, for example, that the lateral incisor is blocked behind the upper canine. So it is a nonsense to engage in the first visit the lateral canine, because it is just an increase of friction, because it will be not moving until there is the upper canine above the lateral incisor. So I have to move backward the upper canine, just applying very light forces that, for example, is the lace back that you can see in the tail here in the picture. And only when I have unblocked the lateral incisor, I can start moving the lateral incisor. In this way, I will maintain very light forces. I will be needed very light forces, and I will reduce the amount of friction. That is something that can slow down the speed of tooth movement. So here you can see that, of course, it is an extraction case, so I need the lace back and the bend back in both arches. I can slide activate the lace back on both sides, and that I do not engage the lateral incisor until I have recovered the proper space to unblock the lateral incisor. There is also an elastic chain between the upper canine, because I want to move very slowly the canine backward and, of course, downward through the occlusal plane. The first wire that I can use is a 0.14 night eye. Of course, the first arches are super elastic arches wire, and I just allow, and I have to allow to work the system. So never hurry up during your treatment. Just take the proper time to make the proper tooth movements. So this is the a close-up of the lace back, so a close-up of the partial engagement of 1.3 and 1.2, the application of light forces to create space, and then move the blocked upper lateral incisor. Then we can go ahead with the bonding of the mandibular arch as well, and also in the bonding of the mandibular arch we can make some adjustment to our clinical case. So, for example, we have also in the lower a partial engagement of the lateral incisor, because exactly in the same way of the upper, we have that the lateral incisors are blocked. So before, through the application of the lace back, we have to move backward the lower canine, and then we can move the lateral canine. Here you can see in this close-up that I have applied elastic ligature on all teeth except on the lower canine, because I want to have an early control of tip and rotation to move in a proper way the lower canine. So we can go forward with our treatment. In the upper arch, I applied a 0.16 night eye arch wire. You can see that the lace back are working very well. The band back, that it is a distal band, distal to first molar, are working very well. So what I want during this phase is just a slight backward movement of upper and lower canine, because only in this way I can use in a proper way the extraction site, relieving alignment and leveling. You see that after some appointments, I still not have engaged the lower lateral incisor. So if I go back, you can see here I had less space. The canine is moving backward, and the lateral incisor through the tongue pushing is going forward very, very, very spontaneously. So I take advantage of intraoral forces. The second phase of our treatment is to keep on working on alignment and leveling. So I go ahead with rectangular arch wire before I apply night eye rectangular arch wire, and then I can move to stainless steel rectangular arch wire to finish the alignment and to finish the leveling. When we will be studying the phases of treatment, we will learn that the leveling and the alignment finish during when you applied the stainless steel arch wires. Only at the end of this phase you can start with the working phase. That means start with elastics, with the retraction chains, with bodily movement of teeth. So to reach the working phase, we have applied in the upper arch a rectangular 1925 stainless steel posted arch. It means that we have the post mesial to upper lateral incisor. And since we want to correct the midline discrepancy, we can decide if to apply active tie back only on one side, because we can work with the sliding biomechanics to move the arches maybe more toward one side than the opposite. In the lower arch, it is still working night eye rectangular arch, and this is the progress of our treatment. And at this point, we entered in the working phase. So we have stainless rectangular arches, both in the mandible and in the maxilla. So we have obtained the alignment and the leveling of the arches. We are coordinating the arch form between the maxilla and the mandible. And now we can apply elastic change, especially in the lower arch, to completely close the spaces. And at this point, after I have moved the lower canine backward, I can allow the spontaneous mesialization of the posterior unit. You see that there are some bends that I already performed on the lower stainless steel arch to reach the perfect, the ideal arch form coordinated with the maxillary arch form. And I'm managing and I'm selecting the closure of space in the upper arch. So I'm still working with an active tie back only on the left side because I want to correct and to obtain the midline coincidence. You see that I'm a little bit losing the solid class 1 relationship. So this is the perfect time to apply class 2 elastics. The class 2 elastics, there is all the planification for the elastics according to the force, according to the distance between the application of the elastics, but the meaning of the elastics is to direction in a proper way the sliding mechanics during space closure. So through the application of the class 2 elastics, and at this point, the patient have to be compliant with you, otherwise you lose the balancing of your biomechanics. Through the application of the class 2 elastics, you can reach and you can keep the solid class 1 molar and canine relationship, because if you apply the class 2 elastics, the lower dentition will go slightly forward and the upper dentition will go slightly back. I don't know what is going on my backward. I don't know. Sorry, fatto così, I did like this and something happened, like fireworks.
Yeah, it's probably from Zoom. I don't
Okay,
know what it is.
sorry. Okay, you see that in the lower arch, I keep on closing all the spaces. This is very important because we don't want food impaction in our patients. That can be a very serious problem for our patients. So there is an elastic change. And at this point, we're ready for the finishing phase that starts when the following goals have been accomplished, such as alignment and leveling of both arches, such as the full closure of the spaces, and very important, we already have obtained flat occlusal planes. When we start the finishing phase, we need a panoramic X-ray, because in this way we can check the root parallelism, and it is especially very important and very required when we have extraction cases, because we want to close the extraction space through bodily movement of adjacent teeth, and we want to avoid any kind of tip and uncontrolled tip movement. So there are several things that we have to make better. So we have to improve the position of the roots of the upper lateral incisor, of the first molars, in the lower of some incisor as well. And therefore, during the finishing phase, we can apply we can make some bends, and we will learn how to perform the finishing bends. We can reposition some braces when we have very big mistakes, and we can also increase the thickness of our arch wire to fulfill the slot of our braces. So in this case, I reposition the upper lateral incisor. I reposition also some lower incisor and applied a 2125 beta titanium archway that is soft enough for the repositioning, but it is thick enough to fulfill the slot of braces and therefore to improve the torque control of especially the upper teeth. And this is the end of our patient. So you can see that now we have a very broad and pleasant smile. You can see also that the gingival level are well positioned and maintained. And look at the profile. You remember that at the start of the beginning, we have a more pronounced convex profile, while it is of course, it is an adult patient, so we can change the face completely, but we have a slight counterclockwise rotation of the mandible that allow us to maintain the vertical dimension and to have a better projection, anterior projection of the chin. As well as a smile, she maintained, although the extraction, a good anterior limit of the dentition. This is the occlusal finishing. We have a very beautiful class 1 occlusal relationship at the molar and at the canine. We very well preserved the guides, the canine guides during the displacement of the mandible. We have ideal overjet, overbite, and a good midline coincidence, and the arches are well aligned, level, and coordinating for the shape. This is the final panoramic, so you can see that we manage the root positioning, and now we have a good root parallelism. This is the comparison between pre-treatment and post-treatment of the lateral cephalograms. So we were able to slightly retract the lower incisor, but we kept the good inclination of the upper incisor. And look, on the XA is more evident, the beautiful profile because of the anterior clockwise rotation of the mandible. This is the final value with the comparison between the initial and the final value. The soft tissue cephalometric analysis that, if you want, you can check at the end of treatment. And this is the comparison before and after. And this is the comparison before and after. Okay. I ran a little, but I think that it was a very good case selection because I had the chance to explain different aspects. I hope there are some questions.
Yes, there are. Yeah. So someone is asking how many weeks between appointments?
Okay. Well, usually 4 weeks. But I have to admit that the COVID pandemic taught us that maybe one appointment per month is even too much. So you can choose if see your patient between 4 and 6 weeks. Usually in my practice, I delayed a little, so I see my patient every 6 weeks.
Okay, great. And Diana also is wondering how to manage the gum level of 1-3.
Okay, we have several options. The first option is to put your braces upside down. In this patient, you see that I didn't put the braces upside down because the prescription that I use for my patient on the canine is of 0 torque. So upside down would not change anything. In the original MBT prescription, you have a torque value of less 7 degrees. So if you put the brace upside down, you will change the prescription torque value from less 7 degrees to 7 degrees. It means that if you put the upside down the brace, the bracket, you will push with the plus 7 degree prescription the root inside the alveolar bone. And this is a tip that can be used every time you have a vestibular ectopic eruption of upper canines.
Okay.
The second is to apply very slight force. And if you are not going in a hurry, you can extract the first bicuspid and let it move spontaneously the upper canine. Because since there is the space available backward, the canine will move spontaneously backward and will help a lot the gingival level of the canines. But our patients don't like the spaces, of course, and they want to see, especially adult patients, and they don't want to see the spaces during smile and the functioning. So you have to balance both.
Again, one more question from Diana. What kind of retention have you used and for what period of time?
Okay, sorry, I didn't mention. It is a very good question. The retention is a long life retention. So we reach such a level of precision that we have to advise our patient that if they want to maintain the precision that we get at the end of treatment, the retention is long life retention. The patient asks all the time, are you serious? And I say, yes. In this case, I applied plastic retainer, so S6 removable retainer. Otherwise, you can choose between removable and fixed retainer. Usually the lingual fixed retainer, I use the lingual fixed retainer only in the lower. But she was not a great champion of oral hygiene. So for her, I decided for both removable retainer.
Okay, great. One more question. Alina is asking if the VTO will be explained during the one-year program.
Yes, of course. For this morning, there's no time. But of course, the virtual treatment objective planning is essential, especially during extraction cases, because it helps us in the decision of movement, it helps us in checking the progress of the treatment, it helps us in the anchorage management. So it is a very helpful tool if you want to achieve our treatment goals. Otherwise, we are like blinded. So the virtual treatment objective is, in my opinion, it is mandatory, especially during extraction cases.
Okay, and one last question from Alexandra. She's asking if you will be present for all the modules of the one-year smart straight wire program.
Yes, I will be present during all modules. Of course, there will be some other speakers that are all my they are colleagues and friends, and they will be working together for a lot of time. So we are very well coordinated. But I will be present for sure, because I'm so excited to have this full 1 year full program.
Yes.
I have a lot of master in Italy, but the master is something a little bit different because I'm inside university. I have a lot of private courses, but this is particularly interesting for me because there are new people that I can meet and share with them a lot of knowledge.
Okay, thank you very much, Roberta. That wraps up our session today, and I cannot thank you enough for this wonderful webinar. I'm sure that everyone has walked away with a lot of practical tips and clinical knowledge in such a short time. I can only imagine the amount of information they will gain during the Smart Straightwire program.
Okay.
And those of you that haven't been with us since the beginning of the webinar, Smart Straightwire one-year program is a complete orthodontic program designed specifically for residents and specialists at the beginning of their careers. Together with Roberta, we have carefully structured this program so that all the information can be immediately applied in your practice. So if you want a treatment protocol that gives you a clear direction and allows you to effectively treat more than 90% of your cases, Smart Straightwire is what you're looking for. As I mentioned earlier, we have a little surprise for those who joined us today. You're getting a 20% discount on Roberta's upcoming introductory course in November in Bucharest as part of the Smart Straightwire program. You'll receive an email from us with all the details pretty soon. Once again, Roberta, thank you for being with us today, and we're really looking forward to seeing you in Bucharest in November.
Thank you very much. I hope you enjoyed and have a wonderful day, everybody.
Okay, to everyone who joined us, thank you. Have a great day, and don't forget, there is always something more to learn. Bye-bye.
Thank you very much.